All right, this week we're going to be covering chapter 17. I'm going to do it in half. So we're going to cover fluid and electrolyte imbalances, and then I'm going to do another recording for our acid-base imbalances. So let's go ahead and get started on fluid and electrolytes. So looking at our normal physiology, so body fluids and electrolytes, they play an important role in maintaining our body's homeostasis. Again, remember that our body likes to be in that homeostasis. Everything is within that normal range. They are in constant motion, transporting nutrients, electrolytes, and oxygens to our cells, and then carrying away the waste from our cells. Fluid and electrolyte imbalances occur in patients with major illness or injuries. Some of these examples would be a patient with burns or congestive heart failure. You could also throw in those therapeutic measures, such as a patient who has a colonoscopy done and they have to have the PrEP. They're going to have an imbalance with that. Diuretics, the medication, will cause imbalances for patients. And then we classify this as either deficit or excess, which we'll get into that a little bit more, but you'll hear fluid volume deficit termed as hypovolemia, and hypervolemia is excess. And again, like I said, we'll go into more of that in the slides coming up. But we just want to make sure that as far as fluid imbalances go, it's important for us to recognize these imbalances as soon as possible and intervene with the appropriate actions for these patients, or it could be something that is detrimental to their health. So water content of our body. Our water accounts for about 50 to 60% of our weight, our body weight. Water content varies, so it can vary because of body mass, gender, male versus female, and age. Lean body mass has a higher percentage of water, and then fat tissue has a lesser percentage of water. So older adults also have less lean body mass and have about 45 to 50% water content. So just a little bit different there. They are at a higher risk for fluid-related problems. Again, this is just looking at water content of the body over a lifespan. This is in your book as well. And then let's talk about our body fluid compartment. So intracellular fluid, this accounts for about 2/3 of our body water, and it is found within our cells, so intracellular. About 1/3 is found extracellular, meaning outside of our cells. And then the others are interstitial, which is in between the cells, transcellular, which includes cerebral spinal fluid, fluid in our GI tract, joint spaces, peritoneal space, and pericardial space, and then intravascular, which is within our vessels. So plasma, that's that liquid part of the blood. So calculation of fluid gain or loss. So when we think about water and weighing it, 1 liter of water weighs 2.2 pounds or 1 kilogram. And so body weight change is an excellent indicator of overall fluid volume loss or gain. Think about our congestive heart failure patients and why we watch them very closely as far as their weight gain goes. So if you think about these patients who are gaining 2 to 3 pounds pretty quickly and how much excess fluid that is on their body at that time and what it's doing not only to the lungs but to the heart, that extra work. So that's why we want to make sure we're watching them, is that they're going to go into crisis pretty quickly and need medical intervention. So if we can identify it ahead of time, so we can kind of keep them from going to the hospital or being admitted, that's what we want to do. So here's another example as far as a patient drinking water. So if a patient drinks 240 mLs, that's 8 ounces of fluid, the weight gain will be 0.5 pounds, so 1/2 pound or 0.23 kilograms. Patient receiving diuretic loses 4.4 pounds or 2 kilograms, so fluid loss would be around 2 liters for that patient. I also think about our dialysis patients, and we're talking about taking off some of that fluid. So if you think about when your patient receives dialysis and they removed 2 liters, then you can think about, okay, your patient is most likely to have dropped this many pounds because of that. Electrolytes, these are substances whose molecules dissociate into ions when placed in water. You can have cations, which are positively charged, or anions, which are negatively charged. And then the concentration of electrolytes is expressed in milliequivalents. So you will see this when you're reviewing your patient's labs for different electrolytes. So looking at the electrolyte composition between intracellular and extracellular fluid, in your intracellular fluid, your prevalent cation is potassium. You will have some sodium and magnesium. And then in your extracellular fluid is mainly phosphate with some protein and then a little bit of bicarbonate. Here's the list of normal serum electrolyte values. It's important for you to know these electrolyte values. You will use them a lot in your nursing career. You want to know what the normal range, and then also we'll take a look at some of the ones that are lower and some of the ones that are higher and what you would see within that patient and how to treat it. But these are one of the most important values for you to learn because you, like I said, you will use these over and over again. So why is it important to know normals? So that you can recognize when it's outside of those normals and what to expect. All right, now we're going to be looking at mechanisms that control fluid and electrolyte movement. Start with diffusion. So diffusion is the movement of molecules from an area of high concentration to low concentration. And then that net movement of molecules stops when the concentrations are equal in both areas. And you can see here in the picture where they throw that lump of sugar in the water and then it separates out till everything is equal in both areas. It occurs in liquids, gases, and solids, and it requires no external energy to be able to do that. When we look at facilitated diffusion, this needs a carrier to help move the molecules. So the best example here is the glucose transport into our cells. Those large glucose molecules, it has to combine with a carrier to be able to cross that cell membrane and enter most cells. When we look at active transport, this is a process in which those molecules move against concentration gradient. There is external energy that is needed for this process. So an example of this one is our sodium-potassium pump. The concentrations of sodium and potassium differ between the intracellular and extracellular fluid, and this is to maintain this concentration difference. The cell uses the active transport to move the sodium out of the cell and pushes potassium into the cell. And then the energy source that is used for this is the adenosine triphosphate, which is known as ATP. And then it is made in our cell mitochondria. So that's active transport. So osmosis, it's that movement of water down concentration gradient. It's where water goes from a region of low solute concentration to one of high solute concentration. So you can see here in the picture, they have a semi-permeable membrane, so water can come across, but not albumin. So what happens when the albumin is put in the water, you have 10% on one side of the membrane and 5% on the other. What happens is water is going to be pulled over to that 10% side until it equalizes that albumin. So you can see in that second picture, it's equal 7.5%, 7.5% as that water is distributed on each side. This requires no outside energy sources for this to happen. It just happens. So as far as osmosis goes, I know it's probably been a while since you've learned about that. There is going to be a video in ShearPath for you to watch as well this week. Osmotic pressure, it is measured by milliosmol per liter. It's expressed as either fluid osmolarity or fluid osmolality. They are interchangeable, but they both use different measurements. So you can either see osmolarity or you'll probably see osmolality, but osmolality is the preferred measure to evaluate the concentration of plasma, urine, and other body fluids. So here, osmolarity is measured by the total milliosmol per liter of the solution, and then osmolality measures the number of milliosmoles per kilogram of water. So that's the difference there. The measurement of osmolality, normal plasma osmolality is between 280 and 295 milliosmoles per kilogram. Greater than 295 equals water deficit. So somebody who is dehydrated, their measurements may be greater than 295. And then less than 275 water excess. So maybe looking at somebody who is holding on to excess water. So on this slide, I'm going to talk about osmotic movement of fluids. So the osmolality of fluids surrounding the cells affects them. Remember, osmolality refers to the concentration of solutes, so such as sodium, glucose, and proteins in a solution. It determines the movement of water across cell membranes via osmosis. The body regulates osmolality to maintain homeostasis. So when we look at hypotonic solution, there's a fluid shift into the cell. There's a lower solute concentration than inside the cell, so there's more water outside. The effect on the cell, well, the water moves into the cell, it causes cellular swelling and potentially leading to lysis. The example of a solution for this is half normal saline. So it's used for dehydration, so when cells need more water, but excessive administration can lead to cellular edema, especially in the brain. So we do have to monitor our patients when we're giving half normal saline pretty closely. With isotonic solutions, this is known as normal saline or lactated ringers, there's no fluid shift, so the same solute concentration outside as there is inside. There's no net water movement and the cell maintains that normal shape. We use this for fluid resuscitation. So if somebody has blood loss, dehydration, since it maintains balance without shifting water in or out of the cells. With hypertonic solutions, there's fluid shift out of cells. So there's a higher solute concentration than inside the cell. There's less water outside. The effect it has on the cell here is that water moves out of the cell, leading to cellular shrinkage. The example solution here is 3% sodium chloride or D10. We use this to treat patients with severe hyponatremia, but excessive administration can lead to cell dehydration and neurological complications. So we do have to be very careful and not administer it too quickly. Some key nursing considerations. So we have to monitor patients receiving hypotonic fluids for signs of cellular or cerebral edema, so confusion, headache, seizures. We're going to watch for fluid overload in patients receiving isotonic solutions, especially with somebody with heart failure or kidney disease. We're going to administer hypertonic solutions cautiously as they can cause vascular volume overload and cellular dehydration. Always assess patients' urine output, lung sounds, and mental status when giving IV fluids. So an example here, a scenario I'm going to give you. So a 45-year-old man is brought into the ER after a car accident. He's had significant blood loss. His vital signs show blood pressure 88/50, heart rate is 120, he's cool, clammy skin. So here, what I want you to think about, so blood loss decreases circulating volume, but does not alter osmolality. Isotonic fluids like normal saline or lactated ringers are going to be used to replace that volume without causing any cellular swelling or shrinkage. If blood loss is severe, the patient may require a blood transfusion along with isotonic fluids. So that's the example for that one. So another mechanism that controls our fluid and electrolyte movement, we'll talk about hydrostatic and oncotic pressure. So hydrostatic pressure, that is the force of fluid in our compartment that pushes against a cell membrane or a vessel wall. In blood vessels, hydrostatic pressure is the blood pressure generated by our heart's contraction. So at the capillary level, hydrostatic pressure is the major source that pushes water out of our vascular system and into our interstitial space. So if you look at the capillary here in the picture, at the arterial end of our capillary, that's where our hydrostatic pressure is the greatest. And so that's where it is pushing the water out of there, which is also known as filtration. You will notice that at the end, you have a venous end of the capillary. That net filtration pressure is a lot less, and it actually is where reabsorption takes place. So when we took a look at oncotic pressure, it's also known as colloid osmotic pressure. It's caused by plasma protein. So remember that water moves to somewhere that has a higher solute concentration. So in our capillaries, plasma is the major source of that, and it pulls from our tissue to the vascular place. So what I want you to know about these two and the differences is hydrostatic pressure is where water is pushed out of the capillary, whereas oncotic pressure is when fluid is pulled into it. So push versus pulled. So the amount and direction of movement is determined by 4 factors, and these are the 4 factors. So we have capillary hydrostatic pressure, plasma oncotic pressure, interstitial hydrostatic pressure, and interstitial oncotic pressure. So capillary hydrostatic pressure and interstitial oncotic pressure is what moves water out of the capillaries, while the plasma oncotic pressure and interstitial hydrostatic pressure moves fluid into the capillaries. So fluid shifts. So if the capillary or interstitial pressures change, fluid may abnormally shift from one compartment to another, which can result in edema or dehydration. Increased pressure at the venous end of the capillary inhibits fluid movement back into the capillary, which then causes edema. And then increase in plasma osmotic or oncotic pressure draws the fluid into plasma from the interstitial space. This can result from either administration of colloids, dextran, which is used a lot when patients have surgery, mannitol. You'll see this used for patients with maybe some brain swelling, or hypertonic solutions. So an increase in tissue hydrostatic pressure is another way of causing a shift of fluid into plasma. This can be done by wearing those elastic compression gradient stockings to decrease that peripheral edema. This is kind of a therapeutic application of this effect as well. Fluid spacing. So you will hear this when you're in the hospital doing clinicals, I'm sure. But as far as fluid spacing goes, you can have first spacing. This is that normal distribution between the intracellular and extracellular fluid. Second spacing, this is an abnormal accumulation of interstitial fluid. So this is where you have excess fluid in our interstitial space, and this is what edema is known as. So you can see in that top picture there that looks like some pitting edema. This is that accumulation of interstitial fluid that is really abnormal. In a normal person, you would not have that kind of swelling going on if everything was working correctly. With third spacing, and you'll hear this is the fluid that is trapped where it is very difficult or impossible for it to move back into our cells or our blood vessels. This occurs as ascites, so that fluid is leaking into the abdominal cavity with maybe peritonitis or pancreatitis. It can also happen from extreme burns or traumas where that fluid is going to be trapped, and it's going to be really hard for us to get off of that patient. It can also occur in sepsis. So it kind of just leaks from the patient's extremities. I remember a time when I floated to neurotrauma, and I had this patient that was very septic. And when I moved her just to kind of make sure that we were turning her every 2 hours, and I would lift her leg, this fluid would just kind of leak from her leg. She was definitely third spacing. So when you see it, you'll know it, and you'll hear it when you're working with some of the nurses. All right, let's take a look at the regulation of a water balance in our body. So as healthy adults, we need about 2,000 to 3,000 mLs of water to maintain balance. This is what replaces what our body loses in our urinary output or insensible losses. Oral intake is our most accounted for water intake, but also this includes water from food metabolism and in solid foods. And then that insensible water loss, that invisible evaporization, that sweat, it really helps us regulate body temperature. And then when we look at differences with this or variation, so if you have accelerated body metabolism caused by exercising or increased body temperature like fever, this increases the need for us to replace water. So we may need a little bit more water if that is going on. The two mechanisms that help us regulate, so the hypothalamic pituitary regulation. So there's osmoreceptors in our hypothalamus. It senses either fluid deficit or increase, and then it tells us what needs to happen. So remember that homeostasis going on. So deficit, it stimulates our thirst and our antidiuretic hormone release. Decreased plasma osmolality, it's that water excess. It suppresses that antidiuretic hormone release. And then the other one that helps us regulate water is our kidneys, that renal regulation. That is the main organ for regulating fluid and electrolyte balance. It helps to adjust urine volume. It's a selective reabsorption of water and electrolytes. And remember, those renal tubules are the sites of action of that antidiuretic hormone and aldosterone. So that's where that happens. And then if we have kidneys that are severely impaired, the kidneys can't maintain fluid and electrolyte balance. So this happens when we get edema, potassium and phosphate retention, acidosis can occur, and then there can be some other electrolyte imbalances if this is going on. All right, let's take a look at the adrenocortical regulation. It releases the hormones to regulate water and electrolytes. So glucocorticoids and mineralocorticoids are secreted by the adrenal cortex. That helps to regulate water and electrolyte balance. We learned a little bit about them during our endocrine system, so I'm not going to go into it in too much detail just because we should know about that already. But let's look at that glucocorticoids. That's cortisol. This has that anti-inflammatory effect and increases serum glucose levels. And the mineralocorticoids, that's the aldosterone. So we know that aldosterone, it has a strong sodium retaining and potassium excreting capability. When we have decreased renal perfusion or decreased sodium, it activates the renin-angiotensin-aldosterone system, otherwise known as RAS. This results in aldosterone secretion. And then increased serum potassium, decreased serum sodium, and adrenocorticotropic hormone, ACTH, also stimulates aldosterone secretion. It increases sodium and water reabsorption in our renal distal tubules and decreasing plasma osmolality and restoring fluid volume. So here's a nice picture of how stress affects fluid and electrolyte balance. So again, cortisol is the most abundant glucocorticoid. Large doses, it has that glucocorticoid glucose elevating anti-inflammatory effect, and then the mineralocorticoids, the sodium retention effects. And with normal secretion, this occurs in a diurnal or circadian pattern. And with increased secretion, it occurs in response to physical or psychological stress, which affects many body functions, including our fluid and electrolyte balance. Next is the cardiac regulation of water balance. So we have natriuretic peptides that are agonist to the RAS system. So what does that mean? That means that it suppresses the secretion of aldosterone, renin, and ADH, and the action of the angiotensin II. So in the renal tubules, those peptides promote excretion of sodium and water and decreasing our blood volume and blood pressure. With the GI regulation, this is oral intake accounts for most of the water here. Small amounts of water are eliminated by the GI tract in our feces. And then if we have diarrhea or vomiting, this can actually lead to significant fluid and electrolyte loss. So we always have to think about that for our patients. Gerontologic considerations for fluid and electrolytes. Structural changes in the kidneys decrease the ability for this population to conserve water. Hormonal changes also include a decrease in renin and aldosterone and increase in the ADH and ANP. And then subcutaneous tissue loss leads to increased moisture loss. So all these different things we have to think about with our older population. All right, let's talk about fluid volume imbalances. We'll start with hypovolemia. So if you look at that word and you break it down, hypo meaning less, and then looking at volume, so fluid volume deficit or hypovolemia, used interchangeably. This is an abnormal loss of body fluids, inadequate fluid intake, or plasma to the interstitial fluid shift. Background for this would be usually low extracellular volume, often involving decrease in the sodium and water. Your patient's going to be looking like this. They might have weakness, fatigue, dizziness. They all have an increased thirst. Remember that signal to the brain saying, I need some water. Causes for this would be dehydration, trauma, excessive fluid accumulation between the cells. Some medical conditions that we would be looking at is renal disease and congestive heart failure. So how do we diagnose it? Well, we're looking at some blood tests, maybe a CBC or chem panel, urine test, increased BUN and creatinine, urine sodium concentration, and then urine pH. And then maybe X-ray or MRI, taking a look at some of that disease process, maybe looking at the kidneys or the heart. As far as treatment, we are going to correct the underlying cause and replace water and electrolytes. Hopefully we can do this orally. If not, then we might need to give them IV fluids or blood transfusion. Some of the solutions we are going to see used for these patients is isotonic IV solutions, probably normal saline. You could see dextrose 5% in water used, which is D5W. Lactated ringers can be used as well, and then also ringer solution is another one. Let's take a look at hypervolemia, that hyper meaning more or excess. So you're going to have fluid volume excess. The background here, it's caused by excess fluid intake, excessive sodium intake, or a disease process. Signs and symptoms, weight gain is a huge one. That's the most common for these patients. Confusion, headache, lethargy. Dyspnea, crackles, pulmonary edema. That's the lungs being affected by that fluid buildup and backup. Muscle spasms, edema. You're going to see patients with the pitting edema like in the picture here. What are the causes for this? Well, heart and renal failure, and heart and kidneys are not functioning well. And then corticosteroids, the long-term use of them. And then also with the syndrome of inappropriate hormone secretion. This is excessive secretion of that antidiuretic hormone causing retention of fluid. So what are some diagnosis things that we're going to do? We're going to look at a chest x-ray or CT. Serum osmolarity will be drawn, urine specific gravity, and then hematocrit and the BUN, taking a look at that kidney function. And then treatment, again, it's really treating the underlying causes of it, so possibly diuretics and fluid restriction for these patients, sodium restriction, making sure that we are looking at that as well, because we know that sodium will hold on to water. And then a paracentesis or a thoracentesis. Typically, if these patients are having that third spacing and we're seeing ascites or buildup in the lungs, we're going to do those two and pull off fluid. So nursing management of these patients, well, you're going to do a really good thorough health history, taking a look at kidney, heart, GI, and respiratory problems, any prior fluid balance problems, looking at changes in body weight, and then asking them about their exercise pattern, activity level. Are they excessively exercising or not exercising at all? And then looking at medications, and of course, if they're on dialysis or have had past surgeries. We're going to monitor lab results when available. For these patients, you're going to see a decreased BUN, sodium in hematocrit, and also decrease plasma and urine osmolarity. All right, looking at implementation, so some important elements here are daily weights. You want to make sure that you weigh them daily at the same time. This is the most accurate measurement of volume status for our patients, so we want to make sure that we do it correctly. I's and O's. So this is important to have accurate documentation as well. Think about our patients with heart failure. We want to make sure that we're looking at that, and also for our renal patients. Again, medications are based off of fluid status at times, so we want to make sure that we're giving the physicians the most accurate information so that we don't cause harm for our patients. For cardiovascular care, we're going to be doing vital signs and a thorough cardiovascular assessment. We're going to note any changes in blood pressure. Do they have any vein distension? And auscultating for heart sounds. Remember, S3 can be heard with excess fluid volume, so we want to make sure we document that. And then hypotension is usually seen in severe deficits for fluid. So all those things we want to make sure that we're catching early on. As far as respiratory, with excess volume, we're going to have patients who are short of breath, and we're going to hear crackles. With deficits, these patients have more of an increased respiratory rate because of that decreased tissue perfusion. You're probably going to see some hypoxia, and those patients may need oxygen, just depending on their status. As far as skin care goes, well, let's talk about patient safety first. Again, remember, these patients can be at risk for injury by falls, especially with hypovolemia, with that hypotension. They get dizzy. If they get up too fast, they can fall. So just make sure that we are careful with patients and get them the help that they need if they need to get up to go to the bathroom. And then with skin care, usually looking at turgor and mobility here. So you can see in the picture A and B, if you pinch someone's skin and it goes back to just normal flat, that's good hydration for them. And then in C, if you pull up the skin and pinch it, it usually takes some time for it to go back to a flat status. So these patients here would be identified as some dehydration going on. But what I want you to think about too, but in our older patients, you might not be able to go off that turgor alone because their skin loses that elasticity. So if you pinch it, because of that, it might stay longer, but it doesn't mean that they're necessarily dehydrated. Some other things for that, we're going to assess for edema and maintain good skin integrity and good skin care to prevent breakdown for patients. Looking at fluid therapy, we are going to be carefully monitoring the rate of infusion for these patients and also assessing their ability to do oral intake of fluids, because that's always our number one. If they're able to drink water, then we're going to be offering fluids every 1 to 2 hours, maybe at select times, so when giving medications. And just reminders for patients to finish their drinks to keep that hydration going. Another good thing for us to look at is for those who have some physical limitations, such as arthritis. It's hard for them to open and hold containers or drink. We might want to help them by involving dietitian, speech therapy, occupational therapy, and get them that extra help, especially if they're having problems swallowing and, again, those physical limitations. All right, let's take a look at a question. So in a patient with prolonged vomiting, the nurse monitors for fluid volume deficit because vomiting results in. So the question is asking us about fluid volume deficit caused by vomiting. So we have to understand what we are looking for in the answer. So let's take a look at these that they've provided. So A, fluid movement from the cells into the interstitial space and the blood vessels. B, excretion of large amounts of interstitial fluid with depletion of extracellular fluids. C, an overload of extracellular fluid with a significant increase in intracellular fluid volume. Or D, fluid movement from the vascular system into the cells, causing cellular swelling and rupture. So we really have to know about fluid volume deficit and what's occurring there. So if we look at all of these, I'm going to go back to A. We know that fluid volume deficit occurs when there is loss of both sodium and water, and then intracellular fluid moves into the interstitial spaces and blood vessels. So that matches up perfectly. So I'm going to go ahead and say A. And that is the answer. So again, as far as what it's asking you, it was asking you about fluid volume deficit and what occurs with that. So you would want to know what's occurring with that. So when you're studying, you're going to be looking at that. In the next presentation, I'll be going over all the electrolytes with you. So let's go ahead and go on to the next one.